Good morning, students. Today's lecture topic is prolapsed intervertebral disc, that is also known by PIVD. Here is the anatomy of IV disc, that is intervertebral disc. First, let's start with the anatomy. This is the structure of intervertebral disc. As you can see on the screen, here it is intervertebral foramen. This is ligamentum flavum. Here you can see interspinous ligament. This is supraspinous ligament. Here you can see annulus fibrosus. And this yellow part is nucleus pulposus. This is all what a spinal cord is. This in the middle. This is a spinal nerve, you can see. Here it is posterior longitudinal ligament. This is anterior longitudinal ligament. Moving forward on the next slide. The intervertebral disc consists of three distinct components, as you have seen in the structure. The first one is the cartilage and plates. The second one is nucleus pulposus. The third one is annulus fibrosus. The cartilage ring are thin layers of hyaline cartilage between two adjacent vertebral bodies and disc proper. Moving forward on to the next slide, here you can see the structure of intervertebral disc. These are the vascular channels of the disc. Here you can see the annulus fibrosus. These are the vascular channels, and these are the end plates of the disc. And here it is vertebra. This vertebral end plates, you can see it's of 4 centimeter. This in the middle, you can see the nucleus pulposus, which we have seen earlier in the structure, that yellow part. This is annulus fibrosus, and this is nerve root, which is passing through spine. This is vertebral body, and this is cartilaginous end plate. This is canalibigmus end plate. As you can see in the structure, this is plate and bony rim. Here it is nucleus pulposus. This is annulus fibrosus. As you have seen the structure. Moving forward on to the next slide. Nucleus pulposus. Now here we are going to study that what nucleus pulposus is. Highly hydrated structure. Generally, nucleus pulposus is a highly hydrated structure, which is of approx 88% of water. Hydrophilic matrix, it is composed of proteoglycans. Thus, interspersed with an irregular mesh of type 2 collagen and elastin fibers. The proteoglycans have a large number of anionic glycosaminoglycans side chains, that is chondroitin sulfate and keratin sulfate, which allows the nucleus to imbibe water. Low collagen and high Pg ratio characterized by compressibility. As you can see the structure of nucleus pulposus. Moving forward on the next slide. This you can see annulus fibrosus. You can see the structure as well. Let's study about annulus fibrosus. It is composed of concentric rings of highly organized collagen fibers which are interwoven. High collagen and low Pg ratio. The fibers are oriented 60 degrees to the vertical axis of spine and parallel within each lamella and perpendicular between adjacent lamella. Lamella are thicker anteriorly and laterally and thinner posteriorly. As you can see in the structure, annulus fibrosus functions to contain the NP and maintain its pressurization under compressive loads. It is characterized by extensibility and tensile strength. In the severely degenerated disc, the nucleus has lost all of its ability to cushion the loads, which can lead to the disc herniation. Distribution of loads in the intervertebral disc. Here you can see the picture. The first one is A. In the normal healthy disc, the nucleus distributes the load equally throughout the annulus. B. As the disc undergoes degeneration, the nucleus loses some of its cushioning ability and transmits the load unequally to the annulus. Next, these are the 4 stages of disc herniation, PIPD. The first one you can see is degeneration. This is prolapse. This is extrusion. This is sequestration. It has 4 stages. Number 1 is bulging. At this early stage, the disc is stretched and does not Moving on to the next slide. Second one is protrusion. At this stage, the bud is very prominent and the soft jelly center has spilled out to the inner edge of the outer fibers, barely held in by the remaining disc fibers. The third one is extrusion. In the case of a herniated disc, the soft jelly has completely spilled out of the disc and now protruding out of the disc fibers. Sequestration. Here some of the jelly material is breaking off away from the disc into the surrounding area. Prolapsed disc, commonly called as slip disc. A disc does not actually slip. The common side of it is C5, C6, L4, L5 and L5S1. Moving forward onto this next slide. Now here comes the definition. Intervertebral disc. This is in between the vertebral bodies lies the disc. These discs are like rubber washers and allow movement of the spinal column. The disc contains jelly-like material surrounded by a fibrous ring. When the fibrous ring becomes diseased due to injury or any other condition, then the jelly-like substance is pushed out or prolapses into the spinal canal and causes pressure on the spinal cord and its accompanying nerve roots. Moving forward onto the next slide. These are the two factors of IV, congenital and developmental. The factors include poor nutrition, poor health habits, accumulated, accumulated trauma, which can be caused due to sports, automobile injury, lead to weakening of IV disc. Biomechanical factors, posture, repetitive microtrauma, flexion, compression injury, and tensional injuries. Moving on forward to the next slide. Etiology. Repetitive mechanical activities. This includes frequent bending, twisting, lifting, and other similar activities without breaks and improper stretching. Now, live in a sedentary lifestyle. It is more prone to herniated disc because the muscles that support the back and neck weaken, which increases strain on the spine. Traumatic injury to the lumbar disc commonly occurs when lifting while bent at the waist, rather than lifting with the legs while the back is straight. Next is obesity. Overloading the Malleus segment, poor posture, improper spinal alignment, tobacco abuse. Toxin reduces the disc ability to absorb nutrients, which results in the weakening of the disc. Mutation. In genes, coding for proteins involved in dysregulation of the extracellular matrix, such as MMP2 and THPS2. Moving on forward to the next slide. Here you can see the structure. This is bulging of disc, this is degenerated disc, and this is normal disc. Here you can see the herniated disc. Here the thinning of the disc and disc degeneration with osteophyte formation. You can see everything in one picture. It decreases proteoglycan content. It loss of negative charge proteoglycan side chain. Water loss within the nucleus pulposus. A decreased hydrostatic property, loss of disc height, and uneven stress distribution on the annulus. Moving on forward to the next slide. Here comes the pathology of intervertebral disc. It is a sequence of changes occurring in the disc which lead to protrusion or extrusion of NP through a rent in the AF. The changes consist of the following. Nucleus degeneration. Degenerative changes occurs in the disc before displacement of the nuclear material. These changes are first, softening of the nucleus and its fragmentation, weakening and disintegration of the posterior part of the annulus. Here comes the nucleus displacement. When annulus become weak, either because a small area of its entire thickness has been disintegrated spontaneously or because of the injury. Nucleus tends to build through the defect. This is known as disk protrusion. This tendency is greatly increased if the nucleus is degenerated and fragmented. Finally, the nucleus comes out of the annulus and under the post longitudinal ligament, though it has not lost contact between with parent disc. This is called as disc extrusion. Once the disc is extruded, it cannot go back and is not strong enough to prevent the nucleus protruding further. So the extruded disc may lose its contact with parent disc. The sequestrated disc may come to lie behind the joint or may become free fragments in the canal. Here you can see the structures of normal disc as well as degenerated disc. Here normal disc includes intervertebral disc. This is the vertebral body. This is hyaline cartilage and plates. Here you can see the nucleus prolapses and this is annulus. It is degenerated disc. Here you can see border of normal disc and this is nucleus purposus. This is rim lesion of outer zone of annulus fibrous. And here it is herniated disc. Moving forward onto the next slide. Stage of fibrosis. The stage of repair. That begins alongside of degeneration. The residual nucleus pulposus becomes flattened, fibrous, and finally undergoes calcification. At the same time, new bone formation occurs at the point where the real air has been stripped from the vertebral body and spur formation occurs. Here we can see the normal anatomy of the bulge. This is the mid-sagittal view of the vertebral column. Here you can see deterioration of the annulus fibrous allows the nucleus pulposus to push out beyond the boundary of the disc. This is all what the cut area is. Here it is disc generation. Here you can see trauma causes the annulus fibers to break down. This is spinal nerve. This is complete tear of the annulus allows the nucleus pulposus to ooze out and put pressure on the spinal cord and nerve. This is disc cut. So let's read about the symptoms of PIVD. Lower back lumbar herniated. Symptoms includes severe low back pain, pain radiating to buttock, legs and feet. Walking can be painful and difficult. If made worse with coughing, spraying, or laughing, muscle spasm will be there, tingling or numbness in the legs. Muscle weakness or atrophy in later stage. Loss of bladder and bowel control. Some people do not have any symptoms of PIVD. Research studies where routine back seams have been done on a large number of people which has shown that some people have a PIVD without any symptoms. It is thought that symptoms mainly occur if the prolapse causes pressure or irritation of a nerve. This does not happen in all cases. Some prolapse may be small or occur away from the nerves and cause minor or no symptoms. Here is the management of PIVD. Assessment. The main part is assessment. How will we assess patient? It is by posture. The posture can be rigid or loss of curved spine, that is flattened back and lumbar spine, posterior pelvic tilt, sciatic scoliosis may be present. Movement. Trunk flexion may be painful. Flexion may produce pain. Tenderness along midline or lateral to spinous process. Here it is gait pattern and PIVD. As you can see in the picture, what we can see in the gait is excessive hip flexion. That is due to IT band contractures, hip flexor spasticity, hip flexion contractures, hip pain, compensation for excessive knee flexion and ankle DF, like ankle dorsiflexion, compensation for ASIS, ankle plantar flexion in mid-swing. Most commonly, the excessive hip flexion can significantly change the gait pattern. Hip abductors weakness. During the swing phase, to allow the opposite leg to lift, the abductor muscles stabilize the pelvis. These are some of the special tests of PIVD. Here you can see, in case of PIVD, you can go for foraminal compression, distraction test, upper limb tension test, shoulder abduction test, tunnel sign. Moving forward on to the next slide. Here is the picture how you can perform the following test. It is the picture of foraminal compression, distraction test, upper limb tension test, shoulder abduction test, and tunnel sign. In case of lower PIVD, we can go for some tests like SLR, Lasik test, bowstring test, prone knee bending test, and sensory impairment over dermatomes motor weakness over myotomal distraction. That's how you can perform the test. This is Lasik test. It's also known as straight leg test. That is SLR. This you can see the X-ray of an intervertebral disc bulge. Here this is bulging of disc. This is the MRI scan of PIVD patient. EMG study. An electromyogram test looks at the function of the nerve roots leaving the spine. It is done by inserting tiny electrodes into the muscle of lower extremity. On the basis of electrical signals in the muscles, it shows if the muscle is being pinched or irritating as it leaves the spine. Here comes the treatment part. The one can be conservative and second can be operative. First, let's read about conservative management. Rest. Rest and anti-inflammatory and analgesics. Reduction, continue bed rest, and traction for 2 weeks may reduce the herniation in over 9,096 cases. If no improvement with rest and traction, epidural injection of corticosteroids and local anesthetic are given. Chemonucleolysis. Dissolution of the nucleus pulposus by percutaneous injection of proteolytic enzyme. This enzyme has the property of dissolving fibrous and cartilaginous tissue. Second comes the operative management. Indication for operative removal of disc is cauda equina compression syndrome that does not clear up with 6 hours of static bed rest and traction. This is an emergency case. Second, you will see neurological deterioration while under conservative management. Persistent pain and signs of sciatic tension after 3 weeks of conservative treatment. Here is the home treatment part. When apply cold packs on lower back. Also, you can apply hot packs on lower back. Patients can also use hot water bags or ice bags to reduce localized pain. Heat can be applied to relax the muscles and to promote blood flow. Ice can be applied to relieve the pain. Painkillers such as acetaminophen, ibuprofen, or oral steroids can be taken to reduce the inflammation in the area, but with your doctor's prescription. Here comes the physiotherapy management of PIVD. Before planning the treatment, determines the position of comfort or symptoms reduction. That is functional position. The patient may have extension bias. Patient's symptoms are lessened in position of extension and provoke inflection, for example, PIVD. The next comes inflection means. Patient's symptoms are lessened in position of spinal flexion, bending forward. Alright, provoke and spinal extension, bending backward, example spinal stenosis, spondylitis. Here you can see the picture. This is the picture of standing hamstring straight. Here you can see the quadriceps arm and leg raise. These are the side planks. This is gluteal stretch. Here you can see extension exercise of lumbar. This is pelvic tilt. And here this is cat and camel exercise. Now here comes the sciatic nerve pain, which includes spinal extension. Bending back is contraindicated if when no position or movement decreases or controls the pain. When saddle anesthesia and urinary continence is present, it could indicate spinal cord or cauda equina lesion due to large central disc herniation. This is when patient is in such extreme pain that he rigidly holds the body immobile. Spinal flexion, bending forward, is contraindicated if when extension relieves the symptoms and when flexion increases or peripheral uses the symptoms. Spinal flexion is contraindicated if when extension relieves the symptoms, when flexion increases or peripheralize the symptoms. These are the modalities to reduce pain and spasm. You can use cryotherapy. It reduces the muscle spasm and inflammation in acute phase. TENS you can use to relieve pain in both acute and chronic phase. Moist heat used as an adjunct before applying specialized. This technique is used to decrease muscle spasm. Shortwave dithermy, pulse SWV in acute condition and continuous shortwave dithermy is in chronic cases. IFT. This is used for soft tissue manipulation to reduce local muscle spasm and induces relaxation. Traction may be beneficial to relieve nerve root compression. Thank you.